Okay, sounds good. Then I'll share my screen because I have some slides prepared as well. Let me see. Oop, almost spoiled it there. Okay. So yes, as Finn mentioned, we wanted to talk to you about a paper that we recently published in Nature Medicine. The paper is on estimating the number of incorrect tuberculosis diagnoses in low and middle income countries. And this came from our work with Ted Cohen and Pete Dodd. It was part of an internship that I did at Harvard. So the main idea of this paper was to find out who actually has TB disease or how many false negatives and false positives the current performance, like algorithm performance, has. So we know that TB diagnostics have limited sensitivity, so smear microscopy, but also the RDTs that are being used. And besides these, that also means a lot of clinical diagnosis is still being done across the globe. And I think this is very prevalent when we look at the figure on the right. So the figure shows clinically diagnosed notifications per 100,000 individuals, and the y-axis is the lab confirmed notifications. And it's clear that both of them are still being used a lot. So lab confirmed cases are important, but also these clinically diagnosed notifications. And with clinical diagnosis, it's very hard to estimate exactly what the sensitivity and specificity will be, but we know that it will be difficult to have both a very high sensitivity and a high specificity. So in that case, we know that there will be some false positive TB diagnosis and also some false negatives. And we were interested to see how many of these there were, as well as true positive and true negative diagnoses overall. So we use WHO Global TB database, and this database includes notification data, so we only have the number of positive notifications. And we looked at low and middle income countries, seeing that TB is more prevalent in these countries overall. The data is stratified into laboratory confirmed cases, so that includes cases that have been diagnosed with RDT or smear, but also these clinically confirmed cases, so that's something that we saw in the previous figure. We looked at the year 2023 and did include HIV positivity, as this matters quite a lot for TB. We excluded any country that has less than 100 notifications or was missing data on one of these really important things, such as laboratory confirmed notifications and clinically confirmed notifications, because that was kind of the crux to this, this estimation. We still ended up with quite a lot of countries. And with that, we looked at the assumed testing algorithm. So in essence, we need to know exactly how people go through testing to understand how many people will actually be true positive, false positive, true negative, and false negative. And we have this, we designed this testing algorithm based on what we think would be most realistic. So I'm just going to walk you through it. At first, we have individuals that are being evaluated for TB. Of those, a certain percentage will actually have TB, and the other will actually not have TB, but are still being evaluated for the disease. They will receive initial bacteriological test. So this might be a smear microscopy, but it also could be any RDT. And if you get a positive diagnosis, that's kind of where the algorithm would end. So you would be considered a bacteriologically confirmed notification, right? You're positive for TB at that point. If you are negative for TB, you will be clinically evaluated. And this clinical diagnosis will ensure some additional positive notifications, and those will be considered the clinically diagnosed notifications. If the patient evaluated actually is negative for both the bacteriological test and the clinical diagnosis, they are considered to not have TB, so they will receive a TB negative diagnosis. Depending on your underlying disease status, your diagnosis might actually be correct or incorrect. So that is kind of shown with the red and blue arrows across. So people that have TB that got an initial positive test result from the bacteriological test are considered true positive diagnoses. So that's this group. And those that did not have TB but actually got positive diagnosis are the false positive diagnosis. And then the people that are going into clinical diagnosis, that considers of a mixture of false negatives, so people that have TB that have been missed by the bacteriological test, and people that do not have TB, and were also correctly diagnosed as not having TB in the initial step. And the same thing happens during clinical diagnosis. We also did some sensitivity analysis to check what would happen if some people did not receive that initial bacteriological test, because we did see that that might be a possibility for some of the countries that we were looking at. I think it's important to know that in this algorithm, we have certain key parameters that actually really dictate how many people were getting a true positive or false positive diagnosis. This is the data that we saw that we are fitting our model to. So these bacteriologically confirmed notifications and clinically diagnosed notifications are what we see in the WHO database. So back to the parameters. What we see is that the initial bacteriological test, its sensitivity will actually determine how many people will be true positive and how many people will be false negative. So depending on the test being used, this might make a difference. So we know that smear has a lower sensitivity than most of the RDTs. So that will kind of skew this balance a little bit. And then for the RDTs, we kind of assumed that the baseline sensitivity and specificity that was being used was from Expert Ultra. But we did do some sensitivity analysis to consider different types of RDTs as well. And similarly, the specificity of the lab test will tell us how many people have false positive diagnosis versus true negative diagnosis. The exact same thing holds again for clinical diagnosis. So we have the sensitivity of clinical diagnosis that determines the number of true positive diagnoses and number of false negative diagnoses. And the specificity of the clinical test that actually determines how many people have false positive diagnosis and how many people have this true negative diagnosis. It's important to note that to be overall false negative, you have to have a negative diagnosis for both the lab test and the clinical diagnosis if you would go through the full algorithm. A really important assumption to our analysis is the fraction of people that have TB that are being evaluated for TB. We assumed that 25% of the individuals being evaluated for TB actually had TB, but we did do some sensitivity analysis to look at different values of this. So we varied this range between 5% to 50%. So if we can find the parameter values for all of these, we can kind of estimate how many people would have each type of diagnosis. And for the bacteriological test, we have a lot of papers, and there's a lot of tests that are being done to see what this sensitivity and specificity is. But it's much more difficult for clinical diagnosis, as it's a little bit more of a subjective type of diagnosis. And it will also vary quite a lot between people. So for that, we used this receiver operator curve. And this curve, it kind of tells us that as people, if clinical diagnosis is more specific, then it will also be less sensitive. So it's kind of this cutoff point to when something is to be determined an actual positive case and something is determined a negative TB case. So it's this balance, this trade-off between specificity and sensitivity. But the main assumption is that it just is infeasible to have both a highly specific and a highly sensitive clinical diagnosis. So we fitted this ROC curve to the published study results that we have from different papers. So if we look at this figure, we see that these dots, they represent published study results, and that is what we fit as this curve to. And we use the middle line, so the blue line, for our main analysis. So somewhere along this line, between this balance between sensitivity and specificity, is what the actual accuracy of clinical diagnosis would be in this study. To ensure that we were doing this correctly and for some robustness, we also did evaluate a more pessimistic scenario. So that's the gray line, the line below. And that assumes that overall the clinical diagnosis was performing a little bit worse than what we expected. And the other way around, we also looked at a more optimistic scenario, which is the purple line, which kind of assumes that there's a higher accuracy possible for clinical diagnosis. As I said before, we did vary initial TB prevalence between 5 and 50%, but our main analysis results come from initial TB prevalence of 25%. And we did see in the literature that 25% seems to be a good assumption. And lastly, a lot of the parameters, values that we have for specificity and sensitivity of the lab tests come from this, with the reference of culture positive TB being set as kind of the reference or the gold standard. And we did evaluate what would happen if we did assume a slight decrease in accuracy due to culture negative TB. So these are kind of the parameters and the model description that went into it. And then we used Bayesian analysis in RSTEN to actually fit the parameter values to the data. So we have this number of bacteriologically confirmed TB notifications over the total number of notifications. And we set this to be the binomial, like a binomial likelihood function. And that way we can estimate the actual values of clinical diagnosis accuracy that would fit into this, so that we would get actually the results that we were expecting to get. Using those values, we can actually estimate the algorithm performance per country and stratify the results based on type of diagnosis. So that will mean the number of false positive, number of false negative, number of true positive, and number of true negative diagnoses. To ensure robustness, we did some extra sensitivity analysis. So most of the, I think I already mentioned, so we did vary the initial TB prevalence between 5 and 50%. But we also kind of consider what would happen if the baseline sensitivity and specificity that we were looking at was actually expert MTB RIF and not expert ultra as we assumed in our main analysis. And we also varied the ROC curve, so looking at the more pessimistic scenario. And lastly, what would happen if people would actually only be clinically evaluated. So we kind of assumed that 25% of those people that were being evaluated for TB did not receive an initial lab test, but just immediately go into the clinical diagnosis. And we were also interested to see what would happen. So some hypothetical scenarios, kind of fractional analysis, where we can see what would happen with the algorithm performance if we consider different approaches. So the first approach that we looked at is to assume that there was this full RDT adoption. So no more smear tests were being given out. And since RDTs have a higher sensitivity than smear, this would hopefully ensure a better algorithm performance overall. We also look at the scenario where we have this reduced clinician willingness. So that means that there is required like a higher level of clinician suspicion to actually give someone the TB positive diagnosis. So that means that there's a higher specificity in clinical diagnosis, but it follows the ROC curve, so that immediately also means that there will be a lower sensitivity, right? So this is still that balance between specificity and sensitivity, but just assume that it's a little bit more on the higher specificity. We also look at what was the optimistic scenario in the ROC curve. So that's kind of what we assume to be a more improved clinical diagnosis. So this could mean, for example, chest radiography is more widely available, and then the clinical diagnosis will be more specific and more sensitive. But it will still always be this trade-off between the two. And the last counterfactual that we considered is this a hypothetical new test being developed that has a higher specificity and sensitivity than the current RDTs, but that also means that clinicians are probably less likely to diagnose their patients with TB because they kind of trust the negative result a little bit more. And so that also means that there's this consequence in clinical diagnosis. So now we can go into the results. So these are kind of the main methods that we used. And with that, we could just estimate the numbers of the type of diagnosis. So I want to show you the aggregated results for the main analysis. So again, assuming 25% TB prevalence. And this is the same kind of figure, the same testing algorithm as I showed before, but now with the actual numbers. So I'm just going to walk you through it. So of the 22.8 million people that were being evaluated for TB, around 5.72 actually have TB, and those are the people that you would want to diagnose with TB as well. Between the parentheses are the 95% uncertainty intervals. So after the initial bacteriological test, 4.2 million individuals will have received a positive TB diagnosis. Of those, 3.7 million have been a true positive, and 0.5 million have a false positive TB notification. All of the other individuals will then be evaluated clinically, and clinical diagnosis will result in an additional 2.56 million TB positive diagnoses. But here you see that you have actually found another 1 million true positive TB diagnoses, but you also have 1.54 million individuals that have a false positive TB diagnosis. So overall, that means that 4.72 million people would have a true positive diagnosis, and 2.05 million people would have a false positive TB diagnosis. Clinical diagnosis will also result in some final negative diagnosis. So that means that 15 million people would actually have a true negative diagnosis, and 1 million people would have a false negative diagnosis. So these are 1 million people that have TB that have not been diagnosed with TB. So overall, 19 million people would have received a correct diagnosis, but 3 million people would have received an incorrect diagnosis. With these values, we can kind of estimate the overall algorithm performance. So if we take into account the true positive and false negative diagnosis, so people that actually have TB, we see that the overall sensitivity was 82.6%. If we look into the false positive and true negative, so people that don't have TB, we see that the overall specificity of the algorithm was 88%. But we can also look into how many people that have TB were actually correct, or how many people of those that were positively diagnosed have TB. So that's the positive predictive value of this algorithm, and that's 69.7%. And the same way we can see of those who were negatively diagnosed with TB, how many actually did not have TB. So the negative predictive value, and that's 93.8%. So this kind of gives the overall picture for the main analysis of the algorithm performance. And this is for all of the countries that we were considering, so the aggregated results. So that means that 1 million people have a false negative diagnosis each year, and 2 million people would have a false positive diagnosis each year, under the assumption that 25% of those evaluated actually had TB. But that means that almost 3 of every 10 individuals diagnosed with TB actually would not have TB, which is quite a large number. So to evaluate our results, we did look at some of the sensitivity analyses. So these are what I mentioned before. So what if a fraction of the people were actually not getting a lab test, but just only being clinically evaluated? What if we consider expert MTB RIF instead of ultra? Or what if we assume a more pessimistic scenario for clinical diagnosis? And in all of these cases, we see that there's still a very high number of incorrect diagnoses. So this is the table with all of the results. So the first row shows the results for the main analysis. So that's what I showed you before. And we see that based on all of these differences, so what if we consider expert MTB RIF, there will be a difference in true positive and false negative diagnosis, as well as false positive, true negative diagnosis, but they were still quite high. And in the same way, if we consider a more optimistic scenario of the ROC curve, so for clinical diagnosis, we see that the false negative diagnosis do actually decrease to 0.72, but there's also decrease in false positive diagnosis, but it's still quite high at 1.78 million. The more pessimistic scenario, as expected, is worse. So that means that now we have 1.3 million people being diagnosed as a false negative, and 2.35 million people are getting a false positive TB diagnosis. And lastly, if people would only get, or a fraction of the people are not getting this lab test, but only being clinically evaluated, the false negative diagnosis actually increases quite a lot to 2.77 million individuals, and the false positive diagnosis decreases slightly to 1.9 million. And I think the more interesting robustness check is to vary the initial TB prevalence, so between 5 to 50%. And here, overall, we still see that there's a high number of incorrect diagnoses, even for the 5% up to the 50%. That doesn't really affect it too much. The values and exactly the balance between the two will actually be adjusted quite a bit. So we see that the false negative diagnoses vary between 0.8 and then the high numbers to 1 million and then go down again. And for false positive diagnosis, we see that for 5% initial TB prevalence, we have about 4 million individuals being falsely positive diagnosed. And then for the 50%, 1.38 million people would actually have a false positive diagnosis. So the last part that I just wanted to show you is some of the counterfactual analysis results. So these are the 4 scenarios that, like hypothetical scenarios that I described before. And they kind of show you a possible way to improve algorithm performance or how we could change algorithm to make it a little bit more accurate. So for example, what if we would consider that there was this full RT adoption, so there was no more smear test, which means that the specificity and sensitivity of the lab test overall will be higher. And on the right below corner, I have the results for the main analysis. So that way it's easy to compare to what we see in this counterfactual analysis. Because we do see a decrease in false positive diagnosis between the main analysis and this counterfactual analysis. And we also see a decrease in false negative cases, but still quite a bit of false positive diagnosis and false negative diagnosis. So this is not the full solution. So then we consider reduced clinician willingness. So in that case, we're assuming that clinicians are less likely to give a positive TB diagnosis such that specificity is increased, but consequently the sensitivity will be lower. And then we see that the false positives, as expected, would decrease to 1.28 million, but that comes at the trade-off of increased number of false negative, 1.22 million. And it also kind of shows you that if you would just ignore clinical diagnosis and would just not have it anymore, that means that you're getting more false negative diagnosis overall. So that clinical diagnosis actually does play a huge part in finding additional TB diagnoses or TB patients. Then we considered the scenario where we are assuming that there's improved clinical diagnosis. So then we have a higher specificity, but this will actually not come at a loss of sensitivity. So as I said before, this might be because there's more chest radiography available to clinicians. And then, as expected, the false negative number remains the same at 1 million. But the false positive number actually decreases quite a lot to 1 million. And the last one kind of looks at this hypothetical scenario of where we have this new RDT that is actually performing better than what we have. So it has a higher sensitivity than the current RDTs. And that automatically would increase the specificity for clinician willingness and also decrease the sensitivity of clinical diagnosis. And then we see that false negatives actually drop to 0.55 million and false positives decrease to 1.32 million. So overall, this would be a good future step to consider the development of new RDT sensitivity, because we see that this leads to a decrease. So these are the results for the 4 scenarios that we considered of true positive, true negative diagnosis as well. And it shows you that in general, the incorrect diagnosis will actually drop down. So that scenario 4 has the lowest number of incorrect diagnoses and seems to be the best way forward, although all of them lead to a decrease in incorrect diagnosis. So now I'm on my final, I'm on my final slide here. So I want to stress that this only applies to routinely used TB diagnostics, but also this considers routine diagnoses. So we did not look at these results for active case finding because that might make a lot of the assumptions quite different. And lastly, there's uncertainty in the parameters. We did a lot of sensitivity analysis to actually account for those, but some of these, such as the initial TB prevalence, were not included in the standard deviations or in the uncertainty intervals. So it's that we did consider like a lot of the different parameters and the range, but they're not included in the actual uncertainty interval. And that means that we see that there's just a lot of false positive diagnoses. And this trade-off between false positive and false negative is always a very difficult thing, and we're not making any judgment about that at all. But we do encourage that there is more research done to this field, and also, for example, by considering better tests that are more accurate, because it does lead to a decrease in incorrect diagnoses. And I think it's important to consider this type of result for future estimates of TB prevalence and incidence, because it actually does have an effect if you're just assuming that all TB notifications are exactly the number of TB cases. That will make the estimates a little bit. You might be overestimating or underestimating actual TB cases. So I think that's what's important about this work. And with that, I want to thank you for your time. And if there's any questions, please let me know.
Thank you so much, Anna. That was really clear and really well presented and very, very interesting. Thank you.
Thank you.
I've definitely got a few questions, but does anyone else have any questions before I dive into some of them? Yes, Lee.
Hi, Anna. Thanks. That was a great presentation. So I worry a lot about culture being treated as a gold standard, and you did mention the issue of culture negative TB. I'm not sure if that, I think you mentioned it in the context of your sensitivity analyses, and I'm sorry if I missed it, but if one is taking into account the possibility of culture negative TB, how does that change your assumptions about the specificity of expert? I would think that the specificity is underestimated and that may lead to overestimation of the number of false positive TB diagnoses. And then the second question I had is just, it was on your last slide where you talked about, where you stressed the fact that this is only for routine diagnosis and not for active case finding. And obviously there's this big push now to do more testing in asymptomatic individuals and to do more active case finding. And it would be interesting just to hear your thoughts on what these results, I mean, I know you haven't evaluated this, but sort of how different would the conclusions be in the context of active case finding? Thanks.
I think for culture negative TB, what we did assume, I think, a decrease in sensitivity of the expert. I'm looking at Nick just to confirm.
Yeah, no, that's right. So for expert and smear, we assumed, so, and for everyone else, the general problem is that our reference standard for TB is a bad reference standard, and that even if we restrict to pulmonary TB, which is what we're thinking about, there'll be a fraction of cases that will be culture negative, so they'll be misclassified on our reference standard. For expert and smear, we assumed that essentially we adjusted their sensitivity down under the understanding that they were being compared to culture, and presumably culture negative TB would also be negative on smear and expert or expert ultra. I realize for ultra maybe you could make an argument it might not, but so we adjusted the sensitivities down. We didn't increase the specificities, but I see where you're coming from on that. For clinical diagnosis, the same applies in that we were looking at the data from the older trial. Well, most of the data for clinical diagnosis came from the trials looking at the WHO smear negative diagnosis algorithm from 15 years ago. I think those trials were conducted, where again, it was a comparison to culture. And there, our pessimistic scenario believed those results as they were given. The main analysis scenario assumed that there was misclassification. So essentially, to analyze those data, we took I think 1/3 of the clinically positive culture negative results and reclassified them as clinically positive sort of true TB. So that's going to improve both sensitivity and specificity for clinical diagnosis. And for our optimistic curve, we actually reclassified 2/3 of those cases. Again, noting that there certainly will be some clinically diagnosed people who are, culture negative. So I think that is an issue. Most of our false positives, like I think 3/4 or more, are coming from clinical diagnosis. So if we did increase the specificity for smear and expert, we would see fewer false positives from that source, but I don't think it would meaningfully change the analysis because most of them are coming from a different place anyway.
Right.
For the active case find, well, Anna, do you want to speak to the active case finding question?
I mean, I think we can do a combination of the two of us, because I think for active case finding, one of the assumption is the difference in the initial TB prevalence. And we did consider quite a wide range of these values, and the analysis was quite robust to that respect. But I think I remember like it would be. Sorry, it's been a while since we did this research.
Yeah,
took a while to publish.
Publishing takes time.
Yeah, but I remember that based on our assumptions, it would actually lead to this would be kind of an underestimation probably of the number of false positives. But I think Nick, you might be able to say a little bit more.
Yeah, well, I would tend to steer away from drawing conclusions for active case finding. We know that for active case finding, starting TB prevalence will be a whole lot lower, but at the same and also the distribution of TB within those cohorts will be different. I would expect to see a lot more, by definition, a lot more asymptomatic TB, and therefore potentially a lot more sort of culture negative TB and people evaluated for sort of in a TB prevalence survey. At the same time, the specificity of those algorithms will be a whole lot higher. Like, I haven't really seen too much evidence of it, but we do know that some individuals will be diagnosed clinically in a TB prevalence survey. Like, well, I've sort of, Lee, you may know better, but I've sort of heard anecdotally there can be clinical diagnoses, but primarily they will all be positive on, culture or expert or smear. So, and I know Ryan's group has done a couple of analyses where they actually think that the specificity could be kind of higher than advertised. So, again, I don't think our results speak to active case finding too well. And also one question you could say, well, don't the routine notifications include some active case finding? And I think for some specific countries, yes. And so like I know Nigeria, if you look at their notifications, I think they're actually going up, and it's understood that that is a product of active case finding interventions. But that, if we sort of look globally, and you'll see we're deliberately only reporting results of globally that active case finding, while present, will be a pretty small fraction of total notifications.
Thanks.
Thank you. I think that maybe does follow into a sort of a question that I had, maybe as a precursor to that, to say that I haven't really thought, I tend not to work in the diagnostic space, so this is outside of my realm really, but I was interested in what you were saying about the assumptions about how much TB there is in that population that you're testing. And it's good that it was really robust to that, because I would imagine that in a lot of scenarios you would be, using things like chest X-ray, and because you're looking at people with symptoms and so on, and potentially have, tried various other things first, that you've got a really enriched population. And I don't know if I would expect that to be more than 50%. I suspect probably 50% is, that would be very high. But I wondered, what if you used anything to sort of lead with your primary 25% analysis, or if that was just we don't really know.
No, yeah, we definitely did use. There was a paper published that would kind of give us an argument to use the 25%. for initial TB prevalence. But since that is exactly, I should say, a very uncertain parameter, that's why we varied it so much between the 5 and the 50%. And that's why we're stressing that these results that we see, like the actual absolute values, are so dependent on the number of people being evaluated for TB and the fraction of people that have TB. Of those people, yeah. So that's of that group. So we did it was based on a paper that we see, based on study results, that the 25% did seem to be the actual good baseline. If that makes sense.
Yeah, thanks.
Yeah, this is if you look at all the, because with Expert and the other, cartridge-based PCRs, there's obviously a huge number of diagnostic accuracy studies done where everyone, where there was culture collected and all of them. So in those studies, the fraction that were culture positive was about somewhere between 20 and 30%. And so you've got to say, well, were those diagnostic accuracy studies in, routine populations? We try to look at the ones that were. I mean, another factoid that bears on this is, the trend in expert, or RDT, so expert or ultra positivity in South Africa, where I think 15 years ago, it started like 15%. Now it's down, it's down to about 8% of all people tested with what is now ultra, I think, or maybe a mix of different tests, but still with, fairly high sensitivity, it's now around 8%. So at least for South Africa, there'd have to be a lot of culture negative, or bacteriologically negative TB for it not to be a kind of low number.
Yeah, no, I was actually going to be one of my questions was in South Africa, where we have like an ICD who have test positivity and test volume and things like that. Could you use it to triangulate? So it sounds like you've basically done that. Which is,
well, using the public, there was a published study that traced those data. I would think we feel we're probably in the right range across, so it's somewhere between 5 and 50, which is obviously a wide range.
Yeah, thanks. Sandeep.
Yeah. Hi, Anna. It is very nice presentation, actually. I enjoyed your talk. So I have just one query. You said that it is done in the low and middle income countries, right? Is it calibrated with individual country or just as a whole? Means when you calibrate your model, is it for the all countries together or individual countries? And whether India is there?
Wow, I'm blanking. Nick, sorry, can you help me out?
Yeah. No, definitely. Yeah. So model fit to every one
Yeah.
of, 100 and something countries for the 2023 data. India is definitely in there, and we are deliberately not showing country-specific results.
No, that's okay. And the next question is then actually what I know from India, India has a public sector and private sector. This is just for information. In public sector, bacteriology confirmed cases is about 70% from public sector notification data. About 70% are bacteriology confirmed, whereas in private sector, which contributes about 40% of the total notification, there 20% is only bacteriology confirmed. Rest 80% are clinically diagnosed. This is just for one information on this. So how many is over-diagnosed, we don't know. How many are getting over-diagnosis or not. And my next question would be not exactly related to this, but what is in terms of public health, which is the better? Means over-diagnosis is better or under-diagnosis in terms of transmission reduction?
I mean, I think our analysis cannot really give an answer to that, to what is better, because it's a very different problem. Like if you are missing people with TB, then obviously you're not treating them with the actual regimen that they need, and that could increase mortality among TB diagnosis or TB patients. But on the other hand, like if you're missing people, if you give people a false positive TB, yeah, exactly, like false positive TB diagnosis, that means that there's a couple of stuff that goes into it. So people are not being treated for their underlying disease, so the disease that is giving them these TB-like symptoms. But there's also like stigma attached to having a TB diagnosis, and their costs that incur with TB treatment, as well as people that in their households might have to be treated for preventive TB treatment as well. And we definitely cannot say which one is worse. That's definitely not for us. We're just showing
That's
you
okay.
this balance. So I think there has been studies done where they tried, find this balance of what is like what should be the trade-off between false positive and false negative. But these results often look mainly at the cost that if you would be missing people with TB or people with the actual disease. So that's hard to say.
Okay, thank you.
Surely,
but it is a good Sandeep. So I want to leverage Sandeep's point just quickly, because I think someone might look quickly at these results and say, oh, look, clinicians are making lots of mistakes. And I think that would be an incorrect interpretation of these data. And that, surely clinicians will make some mistakes, but I see these results as just pointing to, the difficulty of TB diagnosis. And so for a person who, I'm sure clinicians don't think of it this way, but say your posterior probability of TB was 80%, all right? So that's essentially your positive predictive value. Would you treat that person if you had no more information coming in? Probably. If your posterior probability was 50%, like you are 50% likely they had, they had TB, and there's no more information coming. You either get to treat them or don't treat them. What do you do? At some point going down that list, you need to make a decision where you'd say, well, the probability of TB is too low. Clinicians are probably having to make these choices a lot, just simply given the limitations of current diagnostics and the fact that TB signs and symptoms are not specific enough. And so the fact that clinicians are diagnosing some people with TB, even while there is doubt as to whether we know they have TB, just reflects that if they have TB and you miss them, you tell them we don't know what it is, or you start treating them for pneumonia or whatever else, like TB will continue. As Anna said, there's mortality risks, there's ongoing lung damage, there's ongoing transmission. And so very reasonably, clinicians will treat some people even if they're not sure they have TB. So that doesn't mean we need clinicians to change their behavior. We need, better diagnostics. I realize it's a long effort to try and produce those, but this is sort of just evidence of the ongoing need for that.
And I was going to say, surely, Nick, with yourself and Martin and Yasha on the call as health economists, isn't that a question ripe for health economists?
Yep. No, there's other strands looking at this question. I think it is hard. Like, so for a TB program, I think a TB program can be seen as being responsible to the people with TB in a country. I think these results just clarify that a TB program is responsible to the people who are being evaluated for TB, because the harms and benefits fall to both people with TB and people without TB. And so it's really hard to get that balance right in terms of getting it right for the people with TB and getting it right for the people without TB. Like, just as again, it's a factoid. So we conducted a study in Brazil where in their notifications, they still, they don't actually have it now, but they had it a couple of years ago, a record where an individual had a change of diagnosis from TB, so they're receiving TB treatment, and they had a change of diagnosis signaling that the clinical team decided they had something else. So we're like, great, we've because the evidence of false positive diagnoses is very hard to find, but we've got evidence of these false positive diagnoses. And we did, with their help, we had their TB notification data linked to their mortality data system, so we could follow these people over time, even after treatment. Those who had a false positive diagnosis actually had much higher mortality, I think 2 to 3 times higher mortality than the TB cohort. And we think that TB is bad for you, not only while you're, before, during, and after treatment. So these other, false positive diagnoses had much higher mortality. And, digesting those results, I wouldn't interpret that as saying all false positive diagnoses actually have much higher mortality. You think about the clinical situation. These were people. The only time you're going to reevaluate a TB diagnosis is if something's going wrong. And so these are people who are clearly getting sicker or who had other evidence of disease. So the very fact that they were identified as a false positive was kind of a predictor of mortality in itself, and it turns out that a lot of these people had lung cancer. My guess is that only a small fraction of false positive diagnoses have lung cancer or other serious disease like that. I suspect most false positive diagnoses get better because they might have some transient respiratory disease, and that is fantastic. That is what we want for people. We want them to get better whether they have TB or not. But just that means that even if there are a lot of false positive diagnoses, it'll be very hard to sort of see it in the routine data.
Yeah, absolutely. It also reminded me of was it the ACT-TB trial that did sort of looked at trial by antibiotics as a way of diagnosing TB, and I just sort of, it just made me think a little bit about that.
Uh,
That was as a diagnostic, that wasn't good, right?
I don't remember. I don't think it was great, unsurprisingly, but I don't think it was. No, I don't remember, actually. I don't want to misrepresent it.
Yeah. And there is a good point that improved diagnostics for other conditions will help TB diagnosis, right? So even if it's very hard to diagnose TB in some circumstances, if we can do better at identifying the other conditions, that helps.
Yeah, absolutely. If anyone wants to ask a question, do raise a hand. But I guess one of my thoughts following up from your response to Sandeep around not showing country-specific results, I can imagine that is a very good idea, because I would assume what you have varying by countries is, notifications and diagnoses and so on. But the practice, for example, like I just imagine that practice would vary quite largely by countries, and things like prevalence of TB and people who actually end up going through this algorithm and so on. So it would be very difficult to get that sort of country specific without looking at each country very carefully and looking at a lot of those different diagnostic algorithms and tools and all of that stuff. It wasn't really a question.
Yes.
It was more of a...
No, but you're exactly right. Well, Anna, do you want to answer?
No, I just wanted to say that's absolutely right. Because it would be really difficult to vary every single parameter for every single country that we were evaluating. It would just be this huge thing. So we decided to take this approach instead and not make any big conclusions about country-specific results.
And maybe following from that, what I wondered a little bit is how much these kind of things would vary by population that you're looking at. So, for example, kids are more likely to be clinically diagnosed. I assume people, I don't know HIV, but I assume, test performance, it will be quite different in different populations and so on. Is that, do you think that will make a difference? People with low BMI, I think you might, and those are quite a lot of people with TB. Do you think those might affect your results? And I guess I have a preconceived idea of how I think they would affect it. I think they would probably lead to more false negatives. Maybe? I don't know. Do you have any thoughts?
I mean, I can tell you that we wanted to look at age, but the data is not age stratified, so then it would be really hard to actually make these estimates. So we decided not to go with that direction. But we know that I think that mainly for kids, the sensitivity and specificity might be a little bit worse for these tests. So then, that means that more people will be clinically evaluated, and then depending on what clinical diagnosis, I don't really know. I can't say anything about clinical diagnosis for kids, and I'm not sure if that would affect it in any way. I'm not a clinician. And then for HIV, we did include HIV positivity to ensure that this, that would actually adjust the values, because we do see that effect. And HIV positivity was included in the data, so that we can do. With low BMI, for example, it was not included in the data.
Yeah, it's probably one of several reasons for not reporting country-specific results. I think the other aspect of this is that, on the qualitative finding that false positive diagnoses might be, a notable fraction of TB diagnoses. On that, we found it hard to kind of shake this analysis, do it in different ways, change the parameter values, change the model. We found it hard to do those things and not find that false positive diagnoses were a major thing. However, in terms of the specific numbers, there's a lot of uncertainty. And so for country programs, I think it can just be hard to deal with those two things at the same time. We didn't want to report a number for a country when we know that that number isn't going to be the right number, and also that these results, they do have ramifications for how how programs are sort of thought about politically in terms of funding. So I think I think with paper, again, with this analysis does show that false positives are a more prominent feature of TB diagnoses than maybe we would have thought beforehand. There's still a lot of uncertainty about the exact numbers.
Yeah, thank you. If we've got no other question, I had one last very small technical question, which was around your ROC curves. And I think you maybe answered it, Nick, but it basically, it looked like all the data was down here, and then your curve, except for a couple of points, your curves were up there. And that difference was because of your assumption about culture negative. Okay.
Yeah. Reclassification, essentially reclassifying some culture negative clinically positive, right? So that reduces specificity, right? So that's saying clinical diagnosis is less specific, reclassifying them to TB positive, clinically positive. So essentially saying the culture was wrong in terms of their true TB status, and so that at the same time improves specificity and sensitivity.
Yeah, fair enough. Thank you. If there's any last questions? If not, thank you so much again, Anna and Nick as well. That was really interesting and really great to see. I'll stick this up on the TVMac website soon.
Okay, and just one point. Unfortunately, this paper is paywalled. It turns out to publish free at Nature Medicine, you need a small fortune. So if anyone wants a copy of this paper, just write to me or Anna and we can send it to you.
Just I was about to ask this.
Yeah, sorry about that.
Just I was about to ask this paper because I tried to find out and it is you have to access it. I don't have access of that. Yeah.
Okay, I'll send it to you,
please.
Sandeep.
Nick, should I be
Please,
recording
please.
at that point that there's record of you distributing copyrighted material?
Sorry, I'll send you a verbal description of the paper.
Brilliant. Thank you so much, though. That was fantastic. Really, really interesting.
Thank you.
Just to say also, while everyone's on there, we have a speaker for, I think this has counted as our April seminar, even though it's very early in the month. So we do have a speaker in May. I'm just going to check when it is. It's the 28th of May, and it's Layla Larson and Michael Lasaker, who I don't know, talking about characterizing progression and regression patterns across the spectrum of TB. I think this is based on the Arrays TB study, I think it was. So looking at how people progress and regress within that population there, which I think is really important for any modeling that we do as well. So if anyone's interested to join, then it'll be advertised when we send the newsletter out in a week or so. Thank you so much again, and yeah, look forward to seeing you all soon. Have a good Easter break if you're breaking up for Easter.
And same goes.
Bye. Bye, everyone.
Bye bye. Thank you.
Thanks, guys.